There we go. Okay, hello everybody. Thank you for joining us. We're going to go ahead and get into our updates. We have some very exciting updates today. Dr. Martin is officially an associate professor, which is very exciting and very well deserved. And she officially got her R34. So exciting. And we had 2 past conferences this month. So we have lots of pictures. Here's Dr. Martin and her co-presenters at ACOG and some of our residents and students in our lab. And then one of our residents and one of our students. Some more students. Some more students. So exciting. And another resident. And even more exciting news, we have submitted 4 abstracts this past month. We had 2 Project Better abstracts, one by Michelle, one by Sarah. Andrea had a registry abstract, and the Castle students, Ryan and Cerilia and Gabby, had an abstract. So fingers crossed. Okay, and then we have quite a few manuscripts in review. We have 3 for AB, 1 for Michelle, which is what she's going to be presenting on today, and then another SORT manuscript with Hannah and Susie, which was previously presented on. And then we have some recently accepted manuscripts. We have Gus, who just got his manuscript accepted. We had Taylor's manuscript get accepted, and then 2 of Dr. Martin's get accepted. And then here's a screenshot of Gus's manuscript. And then here's our social media promotion. You can follow us on YouTube. We post all of our lab meetings, so if you ever want to catch up on lab meetings, want to learn more about previous research in the lab, you can check us out. Yeah. Oh wait, that was the Twitter. Here's our YouTube. But we do also have a Twitter if you'd like to keep up with our updates. Backwards. Anyway, so next is our current studies going on in the lab. We have Project Better, which provides a theoretically grounded assessment of the feasibility and acceptability technology of a new technology-delivered educational intervention for pregnant and parenting people receiving medication for opioid use disorder. And this study is follow-ups are still ongoing. Chart abstractions are still ongoing, but they're almost finished. And Anna Beth runs this study, and there were 37 participants. And then here are some of the better manuscripts. We currently have 1 in review. And then here are the better presentations. Next, we have Project SORT, which we're going to hear more about today. Michelle runs Project SORT. There were 211 participants, and SORT investigates the relationship between sleep and opioid use disorder recovery. And then here are some of the SORT manuscripts. And then here are SORT presentations. There are quite a bit of these. Next, we have the registry, which currently has 146 participants. And this is an ongoing record to keep track of clinical outcomes of our pregnant and postpartum patients who seek addiction treatment at OB Motivate. And AB and I co-lead this. And then here are the registry manuscripts and registry poster presentations. Next, we have postpartum recovery, which had 26 participants. All follow-ups are complete, all chart abstractions are complete for this study, but this study compares biopsychosocial factors such as pain, mood, impulsivity, and maternal-infant attachment compared during the third trimester of pregnancy and within 6 weeks postpartum between women with OUD. And this study is led by AB. And then here are the poster presentations for postpartum recovery. And the manuscript. Next, we have Project Castle, which the intervention is currently in production, but this is a computerized intervention that educates medical professionals and pre-medical professionals on substance use disorder stigma. And I lead this project. Next, we have our Castle poster presentation. Next, we have our educational studies. So we had 2 previous studies, the medical student substance use disorder curriculum and resident substance use disorder curriculum. But now we have the clinical research curriculum study, which is led by Dr. Madison Marcus, which is exactly as it sounds, a clinical research curriculum for medical students, and it has some undergrad students in it too. And then here are all of our educational study posters. Next, we have the perinatal BUP database. And this was a retrospective cohort study from 2017 to 2020. And the recruitment and primary analysis are complete. We still have some secondary analysis that is ongoing. And this describes trends in buprenorphine dosing during pregnancy and up to 12 months postpartum. And then here are our current posters. Here are the manuscripts for that study. And then here is our pending research support. And then our next lab meeting is TBD, but we will send out an update as soon as we have it scheduled. And then if you have any questions or updates, please feel free to email me.
Thank you, Lilia. The summer does not slow down around here. We had a lot of things going on with all the conferences, and I love all the photos of everyone presenting their research at our conferences this past month. And we have CPDD coming up soon, so we'll have some more good news coming up and some more photos. So thank you. Well, great. Well, on that high note, we're going to move into our research in progress presentation. And Michelle's been working so hard on this study. And like Lilia mentioned, has her second manuscript right now in review with a journal. So she's going to be presenting the second half of the qualitative data from the SORT study. So I'll let Michelle take it over. And Michelle, so we have some new faces. So if you just want to take a moment to introduce yourself and things like that, that would be helpful.
Yes, absolutely. Can you hear me okay? And can you see my screen?
You are
Perfect.
good on both fronts.
Okay, perfect. Well, hi everyone. I definitely see some new faces or new names. So I'm excited to talk with you about this today. So by way of background, for those who don't know me, my name is Michelle and I am a fourth year, although I guess with the summer, maybe fifth year, clinical psych student at VCU, which is crazy. But I think it's also helpful to give like an overview of my own journey. My background is actually in public health, so specifically global women's health. So I did a lot of work abroad in Zambia and Ethiopia prior to coming to VCU. So I have this cool perspective of like global women's health. And I have been working specifically in women's health and substance use, and I've been with the Ivy Lab, I think, for 3.5 years now. And it's been really wonderful. So I've played some roles with the Ivy Lab, but I'm the research coordinator, as Lilia mentioned, for the SORT study, which is where today's data comes from. So this study happened at the Motivate Clinic, and SORT stands for those who might not know, sleep and opioid use disorder recovery and treatment. So this study was a mixed method study, and I'll talk a little bit more about that, meaning that there was a survey and qualitative component that investigates sleep and OUD treatment and recovery. And I welcome any questions along the presentations, and I also will be presenting this at CPDD. So if you have any feedback, anything I should clarify, I would really appreciate that. Okay. So I want to start the background by talking about insomnia a little generally before getting into insomnia in our specific population of interest. So insomnia is defined as difficulty initiating or maintaining sleep, which I know I have experience with. I'm sure everybody on this call has had experience with at some point in your lives. But to qualify, I guess, for a formal diagnosis of insomnia, it's if you have this difficulty falling or staying asleep for at least 3 nights a week. And it's considered chronic or long-term if this 3 nights a week happens for 3 or more months. Anything less than that is called acute insomnia. So the prevalence of insomnia in the general population is pretty high. There's some prevalence estimates that are generally between 5 and 15%, but up to 20%. And the implications of insomnia are really important. They have a lot of public health impacts. And so insomnia is associated with, as you might assume, daytime fatigue and sleepiness, but also a host of negative mental health outcomes specific to my interests in mental health, like depression, suicidality, anxiety, functioning impairment, which just means how you're able to function in your day-to-day life, reduced quality of life, increased healthcare costs, kind of the whole shebang. So insomnia is really widespread, but it's also kind of nebulous, right? There's a lot of causes and contributing factors that help cause and maintain insomnia. Genetic predisposition is a big one. Comorbid psychiatric and medical conditions is another one. Chronic pain is also a really big contributing factor. If you're experiencing pain, it's going to be challenging to sleep. So now I want to talk about insomnia in our population, which is populations using medication for opioid use disorders. So, a lot of attention when I started this kind of journey and learning, I learned a lot about sleep in the process of like active substance use to like early recovery, but there's not that much information about it as it persists into long-term recovery or for those who initiate and maintain onto MOUD. But from what we do know, from some of the limited literature, we know that after initiation onto MOUD, there's definitely sleep problems that kind of persist and maintain for months or years. This is this really interesting systematic review by one of our colleagues, Ali Wilkerson, and I'm happy to send it to people. But that it found that the prevalence was kind of a wide range among MOUD samples, between 19 and 41%. So if we think about in the general population, between 5 to 15, maybe up to 20%, it's even higher in these populations. And this is important to look at, especially knowing that MOUD is a long-term treatment, sometimes lifelong. And research indicates that sleep disturbance might, have negative impact on OUD treatment outcomes. I want to talk a little bit about pathways. Neuropsychology is not my forte. I am not a neuropsychologist, but there's a lot of different proposed kind of neurobiological mechanisms underlying this. So one proposed pathway is that poor sleep might lead to increased impulsivity and stress reactivity, both of which might increase risk of return to use. So interventions that address sleep disturbance is a possible avenue to address treatment retention while stabilized on MOUD. So now I want to shift the focus even narrower from insomnia and MOUD samples to those women on MOUD who may experience unique challenges with sleep. We know that sleep disorders are generally more prevalent in women, and there's a lot of factors that underlie this sleep disparity. So role of sex-specific hormones and genetic factors to other more social determinant of health factors, like caregivers. Women are more likely to be caregivers, which can definitely impact sleep. So this is a fun graphic actually from the first half of the data, the qualitative data that I presented on, I think last year. And this was a publication that came out in September. In the first half of the qualitative data, we explored preferences for sleep interventions among this population. But in those preferences, they were rooted in this triangle, right? So we have found that insomnia, OUD, and gender and other related social determinants play into this relationship, this bidirectional relationship, where each of these three factors are kind of informing each other and shaping the other in that way. Like caregivers, right? That kind of lie along that pathway between insomnia and gender. Caregiving and household responsibilities is both part of an identity of being a parent and also just being a contributing factor to insomnia. Okay. So all of these factors around insomnia, OUD, and gender kind of make the perfect storm among women on MOUD. And we definitely found that to be the case. So from SORT data, we learned that 64% of our SORT sample endorsed clinically significant insomnia symptoms. So if you think back to the past slide about insomnia and MOUD samples, which was, between 19 and 41%, and the general population, which was 5 to 15, up to 20%, this is even higher. And of course, this is a limited sample from a limited population, but I think it's really telling just how much higher our sample endorsed insomnia compared to other populations. But we don't know that much about qualitative sleep experiences among this population, right? So we're learning some of the data on the percentages and prevalence, but qualitatively, what are women on MOUD experiencing as sleep in their life, and how has that evolved over the course of their recovery? Having this information can help inform and develop tailored interventions to address such insomnia among this population. So I hope I've really sold you on the idea. This is really important to look at. The objectives of this study were to explore the intersection of sleep and recovery from the patient perspective among a sample of women receiving medication for opioid use disorder. So again, I will be presenting this at the CPDD conference, so any feedback about this is so welcome. Okay. So this study, SORT overall, was an analysis of survey, which means kind of like the surveys that you do in REDCap, the quantitative surveys that collect these numbers, and interview data, which is qualitative, of women in outpatient OUD treatment at Motivate. So some of the inclusion criteria for the survey were non-pregnant females, had to be at least 6 weeks postpartum, receiving buprenorphine for at least 6 weeks. I think it's important to note that they had to qualify for this study, they had to be non-pregnant or at least 6 weeks postpartum, because pregnancy can be at a really confounding factor to sleep. So women who are pregnant generally are just not sleeping that great. So extricating sleep issues related to pregnancy or being newly postpartum would be really challenging to do from someone just experiencing sleep issues and kind of their day-to-day lives. And they had to be receiving buprenorphine for at least 6 weeks to demonstrate they were stabilized on buprenorphine. So inclusion criteria for the interview. So people were enrolled into the survey. And as part of the survey, they did this insomnia severity index, which is just a measure of insomnia. And the ISI has a range of 0 to 21, higher scores indicating higher levels of sleep disturbance. So anyone who got at or above the criteria or the cutoff of 10 has clinically significant insomnia symptoms. So then we invited those who met that threshold to do this interview. And these were semi-structured interviews based off of these conceptual domains from the socio-ecological model of health. So the interviews were about 30 to 45 minutes, mostly recorded on Zoom, although some were in person, conducted by me with someone else on the Zoom to help take notes or ask clarification questions as needed. Questions were asked verbatim from the semi-structured interview guide with follow-up questions asked for clarification as needed. Okay. So then the kind of methods, we did descriptive statistics using SPSS for quantitative measures. And then we used applied thematic analysis for qualitative, which is just kind of a fancy way of saying that we identified the themes from the participants' words, really allowed them to speak for themselves, and we kind of derived the themes as they naturally occurred within the data. So then we used in vivo to do frequency counts of themes and group words by codes and then themes. Okay. So now to get into some of the results. So the first is just a demographic table. So 11 people participated in these qualitative interviews. So as you can see, of the 11 participants who participated in the qualitative interviews, they were predominantly white, with a mean age of 35. I want to review some of the clinical variables as well, as I thought they were kind of interesting. So we used the GAD and PHQ to measure anxiety and depressive symptoms. And you can see that almost half of them endorsed clinically significant anxiety and over half endorsed clinically significant depressive symptoms. So this isn't necessarily unsurprising, as we know that insomnia is highly comorbid with other psychiatric issues like anxiety and depression, but it was interesting to see in our sample. And we also found that less than half of them rated their physical health as being good or excellent. And then they also endorsed kind of high levels of pain, an average of 6 out of 10 on the pain scale. So the qualitative participants were a population that was experiencing mental and physical health challenges. And you can also see that the average length of treatment for this population was pretty long, 43 months. So yeah, a long time. And for the most part, they were receiving 24 milligrams of buprenorphine. So as part of the survey, we had a whole survey that it was about healthy sleep behaviors. So we asked like a list of what are typically sleep hygiene, but I'm working on reframing as to sleep health behaviors. And then we grouped them into these 4 domains. So these domains were endorsing positive sleep-related cognitions. So for the non-psychologists among us, that means like having healthy thoughts about sleep. So it's okay if I don't get a full night's sleep tonight. Like, I'll be okay tomorrow. It won't impact my day-to-day functioning that much. One night of bad sleep won't hurt me. So these are kind of positive sleep-related cognitions. Also endorsing a healthy sleep environment. So having like a cool and dark room, minimal noise, those are things with a healthy sleep environment. Endorsing sleep restriction. So sleep restriction is a fancy way of saying only using the bed for sleep and sex, because otherwise outside of that, you build associations with bed with other health behaviors that aren't sleep or sex related. And then the last being reducing stimulating activities before bed. So use of caffeine, screen time, etc. The most highly endorsed sleep health behavior domain was a healthy sleep environment using like a cool and dark room and the like. I think it's interesting that the least commonly endorsed health behavior domain was, you can see here, reducing stimulating activities before bed. And this came out a lot in the qualitative data. So, for example, a lot of the behavioral insomnia treatment and guidance is like reduce caffeine and nicotine before bed. All of our qualitative participants smoke cigarettes, and almost all of them drink energy drinks. So that's a really hard habit to address, and that would be really challenging for them. They did not endorse that behavior as highly. And in addition, the second least commonly endorsed behavior was sleep restriction, or only using the bed for sleep and sex. So a lot of our participants were in shared housing situations. They shared houses with family members or roommates, and their room was kind of the only place that they had for themselves. So in that case, it's really hard to only use the bed for certain things. So that was interesting to see some of this qualitative play out in the quantitative data. So now I'm going to talk about some of the qualitative findings. These are really fun. So I will be presenting each theme as well as the summarized sub-theme within the theme. And then I picked one quote to kind of highlight it. So the first theme is that we found that the sample had a lot of multidimensional factors that impact their sleep. So they described things that had a positive impact. So like behavioral strategies that they learned in therapy or rehab, such as mindfulness. A lot of them endorse the use of mindfulness or meditation. Medications that helped with sleep, like melatonin, as well as environmental influences, like having a cool, dark room. But they also described things that had a negative impact. As I mentioned, or I don't know if I mentioned, but all of the 11 participants were parents or caregivers. So they described that this had a significant impact on their sleep, as well as being pregnant or postpartum. So this quote, it's already difficult for addicts to sleep. And then having a baby on top of that. I went into treatment shortly after I found out I was pregnant. I was uncomfortable towards the end of pregnancy. And then once the baby came, it was hard for a mom that's not struggling with addiction. So when you're in recovery, if you're not going to meetings and not meeting with your sponsor, then you're not going to be able to stay clean because you're not sleeping. Even without a baby, it's going to be hard to sleep. And then adding a baby in the mix is very difficult. Okay. Then the second theme is sleep and the journey of recovery. So we found that among our qualitative participants, sleep evolves through addiction into long-term recovery. As I noted, we know a lot of information about what it's like, sleep is like, or disrupted sleep in active addiction, and also disrupted sleep in early recovery, particularly if someone is experiencing withdrawal. But we don't necessarily know what that looks like in long-term recovery. And so we learned that this population still experiences sleep issues. They've just taken different forms compared to what it looked like in earlier stages of their recovery. And really importantly, and a big finding for us, was that participants shared that good sleep reduces risk of return to use, which again has been highlighted as potential pathways in the literature, this kind of relationship between sleep and risk of return to use. But it was very important for us to get some qualitative data to understand the patient-reported nature of it. And this is a quote about that. Okay. And then the third theme was buprenorphine's role in sleep. So participants indicated that buprenorphine played a very important role for them in impacting energy levels for sleep. So it was kind of a mixed bag. Some participants said that it gave them energy. Some participants said that it made them sleepy. So it kind of varied person to person, which makes sense given that people's reactions to medications have, big person like variability. How people react to medications can differ. But it was interesting to see in our population. Participants also showed that buprenorphine affects mental and physical health, and then this subsequently impacted their sleep. For example, as you saw in that table, a lot of participants experienced pain. Some participants indicated that buprenorphine helps with the pain, which helps them to sleep better. And then finally, participants shared that buprenorphine schedules relate to their sleep. So kind of tying buprenorphine to their sleep schedule. Okay. So some of the take-home points from SORT is that we found that sleep health was a really multifaceted, dynamic process among the sample of women receiving medication for OUD. And these findings are intended to inform future investigations of the mechanisms along the sleep OUD intersection. But we also found that the study also reflects the importance of incorporating these really rich patient perspectives into the development of therapeutics targeting this population. So it has been really helpful in making that sell that we really need these patients' perspectives into the development of treatments for this population, which segues very nicely into my next slides talking about the R34 that we just got and how this data is being used to inform that. Okay, I'm just gonna take a drink of water. I'm a chatty Cathy right now. Okay. All right. So yes, this data helped us get this recent grant, which is so exciting. So the title of the grant is Health Equity Informed Delivery of Cognitive Behavioral Therapy for Insomnia Adapted for Individuals with Opioid Use Disorder. I realized in making these slides that I maybe should have made one about CBT generally because there's a lot of non-psychologists on this call. But for those who are not psychologists, so CBT is kind of it's a evidence-based intervention for a lot of mental health conditions. It's used a lot for depression, anxiety, and it's just this idea that thoughts, emotions, and behaviors kind of all influence each other in different ways. And so CBTI is CBT for insomnia, and it is a phenomenal behavioral intervention. It is very, very successful and really does improve insomnia in populations that have gotten CBTI. And so what we're hoping to do, or what we're in the process of doing, is using qualitative data from SORT to inform CBTIO development. So CBTIO being CBTI for people with opioid use disorder. So we are in the process now of making OUD specific modifications to these CBTI sessions and the accompanying workbook, so the kind of handouts and things that patients get alongside the intervention. And we will be developing the CBTIO and then this matched care decision aid. So something that came up a lot in the qualitative interviews was flexibility of how CBTI might be delivered. In person versus virtual is a very personal choice that's kind of guided by a lot of factors. And so we incorporated those factors into this decision aid to help guide a person in the process of making that decision. So we are, yes, making those modifications. And then next we will be finalizing this manual with an expert panel. We will be pre-testing this CBTIO at Motivate. I will be doing the pre-testing. I will be the interventionist as a clinical psychology graduate student. I am trained to do so. So we will be pre-testing that this summer and ramping up for the eventual trial. And then we are also in the process of preparing IRB documents. And this is kind of a figure that goes through the study design of what this looks like. So I think it's really interesting to talk about what CBTIO looks like and how we are making these adaptations. So generally CBTI has like between 4 and 6 sessions, around like 30 to 60 minutes. We are doing 40 or for about 30 to 45-minute sessions. And so the first session of CBT is about like sleep health behaviors and stimulus control. So there's a lot of psychoeducation about sleep health behaviors. And so what we're doing is providing more specific psychoeducation about buprenorphine treatment and insomnia in this population. The second session is about sleep window restriction. So it's a little complicated to explain, but the idea is that if you're only sleeping for 6 hours, you might be spending, between 8 to 10 hours actually in bed. But those hours spent in bed not sleeping aren't very helpful. So at the beginning of CBTI, you work on actually only being in bed for 6 hours. And this is challenging, and there's a lot of, psychoeducation around it, a lot of describing the rationale. But the way that we're modifying it is we're going to use buprenorphine treatment as the anchor when developing their sleep schedule. So something that we learned a lot in the qualitative, as I mentioned, was that a lot of the participants tie their sleep to their buprenorphine schedules and when they take it throughout the day. The third CBTI session is about sleep-related thoughts, a lot of those negative cognitions around poor sleep. And we're going to be doing more specific, targeting more specific beliefs about sleep and substance use. So something that came up a lot in the qualitative interviews as well was thoughts about active addiction or trauma from active addiction tends to come back really strongly when participants are trying to fall asleep. And knowing that this isn't a PTSD treatment necessarily, but this is a way to kind of help people sleep when they're having those memories, is a big part of what this looks like. And then the fourth CBTI session is just review and maintenance of all of the things that they learned in the CBT. And so we kind of think of it as sometimes there's return to insomnia, right? Sometimes your insomnia alleviates, but then you at different points in your life, you go through just times when it comes back. And so kind of this return to use as a holistic concept with like insomnia and opioid use. And so those are what the 4 sessions kind of look like. And then I wanted to pop in a quick section from the manual to demonstrate what this kind of actually looks like. So when an interventionist or someone administering the CBTI does a session, they have a manual in front of them to help guide the session. And so in regular CBT, you're working on establishing bed and wake time. So you're working on building a consistent schedule of when someone should go to bed and when they should wake up, and working with them to implement that schedule every day, even on the weekends. And so we're modifying it by asking about their buprenorphine schedule and getting more information about that and figuring out how to tailor those sleep schedules around their buprenorphine schedule. And then this is the decision aid that I had talked about. So we're in the process of drafting and finalizing this, but I think this is a really helpful thing to kind of demonstrate a lot of what we found in the qualitative data. So some of the barriers that participants described to in-person sessions were access to transportation, caregiving duties. Some of them really preferred to be in person because they felt it kept them accountable to the therapeutic relationship. So all of these factors were involved in this decision aid to see what kind of modality might be best for these participants. And so we're in the process of that. It is a really fun time. It is really, it's great to be able to modify this. And it's been really fun for me to be at the beginning of this, from conducting the qualitative interviews all the way to intervention development. So yeah, I welcome any questions. I'd love to hear from y'all what you think. Any feedback, reflections, that'd be great.
Awesome job, Michelle. That was wonderful.
Thank
I
you.
feel like you took all of our great work over the last couple of years and distilled it so well. And it's such a great, exciting kind of end product that we're working towards now. So I just want to also give you props. Michelle has done an absolutely tremendous job leading this study from the very beginning. So, and it's been really, really nifty to kind of share the data with other people in the research and the clinical world already, and start to see how we can continue to drive tailored treatments for our patients, where a lot of times they're excluded from things that are typically coming out in the data and in the evidence to help people with insomnia. So, but they won't be ignored anymore in the research because of what we're doing along with some other groups.
Yes, absolutely.
Yeah. So I'll open it up if anyone has any questions, clarifications, or any comments really about any of the data that Michelle presented. Again, knowing that she'll be presenting this in a couple weeks or so, the CPDD is coming up very soon. So any clarification questions too are actually really helpful.
Hello, this is Deshonda Taylor. Can you hear me?
Yes.
All right, great presentation. Thank you so much for all of that work. And it was really interesting. One thing that you talked about during the initial part of the presentation before the planning part, and then a little bit with that was about how people are kind of doing their sleep timing or basing their sleep around their buprenorphine use. Can you talk about that a little bit more? Um, like I don't know if I didn't see, like, for instance with the slide, if that one had a quote about that. So like how were people were they taking the medicine and then they knew that they were going to sleep for a few hours after that, and is that what you meant by that?
Yeah, exactly. So what we learned from the qualitative data is some people felt that the buprenorphine made them a little groggier. So they would time it during the day into when they could accommodate for these grogginess. And then yet others said that it gave them energy. So they would also time that, especially like in the morning times when they were waking up, to kind of center around when they wanted to be more alert versus it was okay to have this flexibility and grogginess. So the idea is that we're going to help them identify these times because Dr. Martin explained to me pretty recently that their schedules are pretty fixed. They, take a lot of care in developing these schedules and these routines. So actually centering the sleep schedule around the times that they take buprenorphine would be more helpful than trying to make a sleep schedule and then asking them to tie their buprenorphine to that. So it's really about centering when they're taking it. And again, yeah, when during the day they take it, if it gives them energy or makes them groggy, and what that looks like for them.
All right, thank you, because I was thinking about the administration and it, I didn't know how often the buprenorphine was administered to them, and then like if people usually had to take it like at the same time every day. Like I know sometimes other medications may interact with things and they may have to take it at a specific time due to that, but generally if people took it in the morning, or did they generally advise taking it at night or something like that?
Yes, and Dr. Martin and Margie can speak to this so much better than I can as clinicians that do that. But from what I remember from SORT is that sometimes they take it once a day, 2 times a day, 3 times a day, and it tends to be around the same time. So those that are taking it 3 times a day, they take it in the morning, afternoon, evening typically, and they do take it around the same time every day. And those that are taking it 2 times a day, it's maybe morning and mid-afternoon or morning and evening. But yeah, from what I learned, it's pretty fixed times.
All right, thank you. And then my last question, I'll be quiet, is about the CBT IO. So with the options for the virtual versus the in-person, is it individual sessions, the CBT IO, or are there group options?
Yeah, that's a great question. This will be individual level. So I will be the one administering it for the pre-testing. And typically CBTI is delivered individually, but sometimes there are CBT groups, but we'll be doing individually. But that's a great question. All of those were great questions, Deshawn. I appreciate that.
All right, thank you so much, and good luck with your presentation. I'm sure you'll do well at the conference. Enjoy.
Thank you very much. I appreciate it.
Any other comments or questions that people have? I'll just comment on the last thing that DeShonda Taylor said about the group versus in person. It's funny because in addiction, a lot of times um, behavioral health things are in group settings. It's just kind of the nature of addiction medicine, addiction treatment. But in the research setting in the past, we actually did a study, gosh, a long time ago, and it had a qualitative component, and we wanted to learn actually feasibly what patients would want to do. And these were all postpartum patients, so that's one thing to know. But we asked, would you want to do your qualitative interview one-on-one in a semi-structured interview, or would you want to do it in a focus group setting? So a few years ago, we did that on purpose to kind of learn how should we try to do qualitative research going forward with the patients at Motivate. And in that prior study, no one wanted to do a group. They all wanted to do an individual semi-structured interview, which is not really surprising at all given what we clinically see. So we clinically see that, at least in our patient population that we see with OB Motivate, that patients generally are going to prefer, at least with us, the individual counseling than a group counseling. We have groups at Motivate, and all patients are welcome to use it, and a lot of our patients do. But when you ask people generally what their preferences is, it's generally on the individual side. So, but that was really helpful when we gave patients flexibility in the past, because we were able to get data to back up our decisions. So later on, when people who don't treat patients actually are looking at grants, but in determining if you should get money for them or not, but don't actually see any of these patients, you can add numbers to say, oh, well, this is the reason why we're doing individual sessions versus group for other types of qualitative studies, because in this prior study, we found that no one wanted to do focus groups. Therefore, if we made patients do focus groups for our qualitative component, we would have no one enroll in our study probably. So we learned that a few years ago, and it's been helpful to use that going forward for our qualitative studies. Anyone else have any other questions or comments? Well, great. Well, Michelle, you did an excellent job. Thank you again. And we're excited to move all the hard work of SORT forward to actually create something for the patients and test it out and get it out there.
Yes, very excited about it. Thank you, everyone, and listening. I really appreciate it.
Thank you so much for your work.
Thank you.
Thank you, everyone, and we'll see you next month.
All right. Take care.
Bye.